Hi there, welcome to this warm-up review. Let's get started. First question. Which antibiotics inhibit prokaryotic protein synthesis at the 30S ribosomal subunit? And which ones at the 50S ribosomal subunit? So the mnemonic is buy at 30, sell at 50. So the A in the AT is for aminoglycosides like gentamicin and tobramycin, and the T is for tetracyclines. Then the sell at 50 part of the mnemonic is spelled CCELL, which stands for chloramphenicol, clindamycin, erythromycin, and other macrolides like azithromycin or clarithromycin, L for lincomycin, and then the other L for linazolid. And then also the streptogrammins. Next question. What are the criteria for the diagnosis of a major depressive episode? So remember, you need to have 5 out of the 9 Diggs-Capes symptoms. So D for depressed mood, diminished interest or anhedonia, feelings of guilt or worthlessness, sleep disturbance, impaired concentration, appetite changes, and psychomotor agitation or retardation, loss of energy or fatigue, and suicidal ideation. So you have to have 5 of those for at least 2 weeks, and one of the symptoms must include either depressed mood or anhedonia. Alright, that's it for this warm-up review. Let's move on to the lecture.
In this video, we're going to talk about kidney failure, which includes both acute kidney injury and chronic kidney disease, or chronic kidney failure. And then we'll talk about a handful of diseases that can cause kidney failure. Now, we've already discussed nephrosis and glomerulonephritis in other videos, but these can certainly lead to renal insufficiency and full-blown renal failure. In this video, we're just going to focus on pathology that hasn't been covered elsewhere. So when there's some injury or disease of the kidneys that causes a sudden decline in renal function and a sudden rise in the BUN and creatinine, that's called acute kidney injury. For years and years, this was called acute renal failure, but now we call it acute kidney injury because the kidneys don't have to completely fail. But if the baseline creatinine is 0.5 and then suddenly creatinine rises to 2.5, that's acute kidney injury, even though technically the kidneys are still functioning somewhat and they haven't failed altogether. Or sometimes patients will have some chronic renal insufficiency and the baseline creatinine is around 2.5 and then suddenly the creatinine rises to 4.5. So that's acute kidney injury superimposed on chronic renal insufficiency. It's useful to divide acute kidney injury into 3 broad categories based on what causes it: pre-renal azotemia, intrinsic renal disease, and post-renal azotemia. Now, azotemia just means excessive nitrogen compounds in the blood. Azo is nitrogen, right? So when the BUN, or blood urea nitrogen, is elevated, that's azotemia. It's just a fancy word for high BUN, because in medicine we like to make things unnecessarily complicated. So for the moment, I want you to think of the kidney as a bean-shaped factory that filters blood and converts plasma to urine. Pre-renal azotemia occurs when something reduces the inflow of blood. It's pre-renal. The problem is occurring before you get to the kidney itself. The actual blood filtering and urine-making equipment of the kidney is working just fine. The problem is upstream from the kidney. Then post-renal azotemia occurs when there's a problem with the outflow of urine, some obstruction downstream from all that urine-making equipment. And then intrinsic renal disease means that the problem is in the urine-making equipment itself, the glomeruli and the nephrons. There's something intrinsically wrong with the kidneys themselves. Pre-renal azotemia is very common, especially in hospitalized patients. Causes include things like hypovolemia, such as acute blood loss or diarrhea, or you might see pre-renal azotemia from hypotension, such as in the case of CHF and decreased ejection fraction, or from portal hypertension and arterial vasodilation. Sepsis or cardiac arrest can also lead to hypotension and pre-renal azotemia. And you might even see it from excessive NSAID use, because NSAIDs inhibit prostaglandin synthesis and lead to some vasoconstriction of the afferent arterioles. But the bottom line is that there's underperfusion of the kidneys. So say you have a patient who codes and you resuscitate them, but the next day the BUN and creatinine starts rising. That's probably pre-renal acute kidney injury. Now, intrinsic renal diseases that cause acute kidney injury include things like glomerulonephritis, which affects the glomerulus, acute tubular necrosis, which affects the epithelial cells of the nephron tubules, and acute interstitial nephritis, which affects the interstitial tissue around the tubules in the glomeruli. There are certainly more causes of this, but those are the big ones, especially glomerulonephritis, which is covered in a separate video, and also ATN, which we're going to cover in a little bit. And then post-renal azotemia means there's some urinary tract obstruction, which is often due to prostate disease in men, either BPH or possibly prostate cancer, other urinary tract neoplasms such as bladder cancer or congenital anomalies, or even kidney stones. And you really need bilateral obstruction to result in acute kidney injury and azotemia. If there's a mass or a stone affecting just one kidney, the other one can usually pick up the slack and keep the BUN and creatinine under control. So when you're seeing a patient with an elevated BUN and creatinine, how do you determine if it's pre-renal or post-renal or intrinsic renal disease? Well, the classic test is called the fractional excretion of sodium, or the FENA. Now, before we look at the formula, I will say I don't know this calculation to be high yield for step 1. They may calculate it for you. And even though you can look up the formula when needed, I guarantee this is going to come up during your internal medicine clerkship because acute kidney injury is very common in the hospital. So I'm going to go over it briefly because I don't know that calculating it is high yield, but you should be able to interpret it for your exam. The FENA, or fractional excretion of sodium, is basically the fraction or percentage of the sodium in the filtrate that ends up being excreted in the urine. And you calculate it by multiplying 100 times urine sodium times serum creatinine divided by serum sodium times urine creatinine. I remember that the small numbers go on top and the bigger numbers go on bottom. Urine sodium is smaller than serum sodium. Serum creatinine is a lot smaller than urine creatinine. When you calculate it, the FENA is normally around 1%. In pre-renal disease, the FENA is generally low, less than 1%. And in acute tubular necrosis, which is the most common cause of intrinsic renal disease, the FENA is generally high, greater than 2%. It's not always the case, but it's a decent rule of thumb. Now, I hate to memorize something if I can simply reason it out instead. So think about pre-renal disease. There's underperfusion. Either the blood pressure is low or the intravascular volume is low. And remember, the urine-making equipment inside the kidney is basically fine. So how does the kidney respond to inadequate perfusion? By retaining sodium and retaining water and expanding the intravascular volume. So if the kidney is reabsorbing sodium, taking it out of the filtrate and putting it back into circulation, the fractional excretion of sodium will be low, and urinary sodium is low. So pre-renal kidney disease leads to a low FENA. But if there's intrinsic renal disease, that diseased kidney can't reabsorb sodium normally. So more sodium ends up in the urine, and fractional excretion of sodium is high. That's how I think about it. Another potentially useful lab for differentiating pre-renal from intrinsic renal disease is that in pre-renal disease, the ratio of BUN to creatinine is usually high, greater than 20 to 1. In addition to reabsorbing sodium, the kidneys will reabsorb more urea in pre-renal disease, so that BUN to creatinine ratio is higher. Definitely know that. In intrinsic renal disease, the ratio is in the range of 10 to 1 or 15 to 1. Normal BUN is around 10 to 14, and normal creatinine is around 1. So the normal BUN to creatinine ratio is 10 or 15 to 1. And what about post-renal disease? Well, it's harder to diagnose with labs because the lab results are variable. But you can do imaging like an ultrasound to look for evidence of hydronephrosis or dilated ureters or bladder distension. Let's talk about the results of renal failure. So what happens to a patient when the kidneys start shutting down? Well, first think about what healthy kidneys do. They handle fluid balance, electrolyte balance, they keep the pH balanced, they activate vitamin D, which influences calcium absorption in the GI tract. They produce erythropoietin, which is a hormone that stimulates red cell production in the bone marrow. And the kidneys excrete urea, which is a nitrogen-containing waste product from protein and amino acid metabolism. So in kidney failure, we can see volume overload, resulting in peripheral edema, pulmonary edema, heart failure, hypertension. One of the more significant electrolyte abnormalities is hyperkalemia. That's a big problem in kidney disease. High phosphates or hyperphosphatemia is also a problem, but hyperkalemia is a more life-threatening acute problem. And so is metabolic acidosis. Now, if the kidneys don't activate vitamin D, that leads to a metabolic bone disease called renal osteodystrophy. We're going to talk about that separately. Anemia can occur from decreased production of erythropoietin. And we said that excess urea is called azotemia, but when that urea gets really high, it causes something called uremia. Uremia is a syndrome that includes anorexia, nausea and vomiting, skin changes, pericarditis, platelet dysfunction and an inability to stop bleeding, and encephalopathy, which could manifest as lethargy, confusion, seizures, coma, and death. And chronic kidney disease also leads to hypertriglyceridemia. It's not fully understood why, although it seems to have something to do with impaired clearance of triglycerides from circulation. So some of these, like volume overload and hyperkalemia and metabolic acidosis, are seen with both acute kidney injury and chronic kidney disease. But metabolic bone disease, anemia, uremia, and hypertriglyceridemia are pretty much exclusive to chronic kidney failure. Let's spend a moment thinking through renal osteodystrophy. The kidneys are responsible for activating vitamin D by adding a hydroxyl group to 25-hydroxy vitamin D to make 1,25-dihydroxy vitamin D, or calcitriol, which is the biologically active form of vitamin D. So in kidney failure, this activation doesn't take place as efficiently, which means the patient can't absorb calcium as well in the GI tract. And then as serum calcium decreases, the parathyroid glands produce more parathyroid hormone. So this is a form of secondary hyperparathyroidism. And that parathyroid hormone induces bone resorption to help maintain the serum calcium level. So we call this renal osteodystrophy. There's tissue degeneration or dystrophy of the bones, with thinning of the bones and sometimes abnormal mineralization. We generally treat this with calcium and vitamin D supplements. Next, let's talk about some intrinsic kidney diseases that can cause renal failure. Intrinsic diseases include mainly glomerulonephritis, which are covered elsewhere, and tubulo-interstitial diseases, which affect the nephron tubules or the interstitial tissues. These are not nearly as high yield as glomerulonephritis, but let's hit the highlights of these, starting with acute tubular necrosis. Acute tubular necrosis, or ATN, is acute necrosis or death of the epithelial cells that form the renal tubules. This is one of the most common causes of acute kidney injury, especially in hospitalized patients. So the patient suffers some insult that causes the tubular epithelium to die, and then the patient becomes oliguric, the BUN and creatinine rise, and then they become acidotic and hyperkalemic. This is potentially fatal, and then if they survive, the acute kidney injury could last for 2 or 3 weeks before the BUN and creatinine start to fall, the patient starts making urine again. So what kinds of insults cause this tubular necrosis? Well, the two big categories are ischemia and nephrotoxins. Take a look at your study guide. Ischemia can result from prolonged hypotension, sepsis, particularly septic shock, blood loss, surgery, particularly surgery to repair an aortic aneurysm where you have to cross-clamp the aorta. And then CHF is an unusual cause of ATN for reasons that are not entirely clear. Now, renal ischemia starts off as a pre-renal injury, technically, but that ischemia can damage the tubules and lead to ATN that will persist even when renal perfusion has been restored. So if you have a patient that gets septic and the BUN and creatinine starts to rise, but even a week later after you've corrected the sepsis and you're perfusing the kidney just fine, the BUN and creatinine stay elevated, that's more likely ATN secondary to sepsis and ischemia rather than prolonged pre-renal azotemia. And what labs might help you figure that out? The FENA, which is going to be high in ATN and low in pre-renal azotemia. And then also the fact that the BUN stays elevated despite correcting the volume depletion. That suggests something other than pre-renal azotemia. Then besides ischemia, the other big category of things that cause ATN is nephrotoxins. This includes drugs like aminoglycosides and the cancer drug cisplatin. There are more drugs that do this, but they're uncommonly used drugs, things like pentamidine and foscarnet. And then another important nephrotoxin is radiocontrast that we use for CTs or angiograms. We really don't know why IV contrast causes ATN, but it does. And then another big one is myoglobin, specifically in the setting of rhabdomyolysis. So rhabdomyolysis occurs when there's massive muscle breakdown from a crush injury or prolonged seizures or a heat stroke or cocaine use, or even rarely from statins. And as the muscle breaks down, myoglobin spills into the blood, and then that myoglobin goes to the kidneys. The myoglobin gunks up the kidneys, and that leads to acute tubular necrosis. And then one recent development is that some synthetic cannabinoids like K2 or spice can potentially cause direct nephrotoxicity in ATN. And that may also cause rhabdomyolysis. The kidney biopsy may show sloughing of the tubular epithelium cells into the lumen of the tubule. So instead of the tubules being nice and open looking, they sort of look constricted or clamped down. You should also know that ATN classically causes muddy brown casts in the urine. We'll talk about casts in detail later, but remember, muddy brown casts with ATN. Another intrinsic renal disease is acute interstitial nephritis, which is also called drug-induced interstitial nephritis or allergic interstitial nephritis or tubulo-interstitial nephritis. It's got a little bit of an identity crisis, but I'm going to stick with acute interstitial nephritis or AIN. AIN is nephritis, or inflammation of the kidney, that affects the interstitial tissue, the cells and support tissue that surrounds the tubules. You can remember the typical presentation of AIN with the word fear: fever, eosinophilia, azotemia, and rash. Now, we looked at this in immunology when discussing causes of eosinophilia. So here are the tubules, and then in the interstitium there are lots of inflammatory cells and plenty of eosinophils. So fever, eosinophilia, azotemia, and rash, sort of a diffuse maculopapular rash. it's a drug rash, an allergic rash. The most common cause of AIN is drugs or medications. Remember, it's sometimes called drug-induced interstitial nephritis. So the most common offenders are NSAIDs, penicillins and cephalosporins, ciprofloxacin, rifampin, which is used for TB mostly, sulfonamides like TMP-SMX, diuretics, many of which are also sulfonamides, PPIs, cimetidine, and the gout drug allopurinol. There are also some other conditions that can cause AIN, like lupus and sarcoidosis and certain bacterial infections, but the main cause to know are the drugs. And then we treat AIN by stopping the drug that caused it, and possibly by giving some high-dose steroids for about 2 weeks and then gradually tapering off. But often, AIN will resolve on its own once you stop the drug. Another renal pathology is renal papillary necrosis, where there's renal ischemia that leads to necrosis of the renal papillae, and then they slough off. This usually causes gross hematuria, which may or may not be associated with flank pain, and also azotemia and hypertension. It can be triggered by pyelonephritis, by the use of analgesics, especially acetaminophen and possibly NSAIDs, by diabetes and sickle cell disease. And the last pathology is diffuse cortical necrosis, or renal cortical necrosis. So this is acute generalized cortical infarction of both kidneys, which is pretty rare nowadays. It was classically seen in pregnancy as a complication of placental abruption or amniotic fluid embolism or massive obstetric hemorrhage. But basically, these things would trigger arterial vasospasm and renal ischemia, plus DIC, or disseminated intravascular coagulation. And then the patient would develop flank pain, because ischemia is painful, plus hematuria and oliguria, and possibly anuria. Let's finish up with urinary casts. Casts are often difficult to identify, but they can be helpful diagnostic clues. In the study guide, it says, in which diseases are each of the following types of urinary casts commonly seen? Well, first of all, what are casts? Casts are made up of TAM horsefall mucoprotein, which is secreted by the tubular epithelial cells. And under the right conditions, this mucoprotein will accumulate in the distal convoluted tubules and in the collecting ducts, and then be sloughed off into the urine. And you'll see they basically have formed little casts of the tubules, which may or may not have cells embedded in them. And the presence of certain types of casts in the urine can indicate certain disease states. The first one is hyaline casts, which are basically transparent and pretty hard to see. You can see hyaline casts in normal patients with no renal disease if the urine is concentrated. If they have low flow of urine, they're not flushing out all that TAM horsefall mucoprotein and it builds up a little bit. Or if they're on diuretics, they get a little dehydrated. So basically, other types of casts will form when cells and cellular debris are embedded in the hyaline cast. So hyaline casts are not pathologic. RBC casts indicate there's some type of glomerular bleeding, such as glomerulonephritis. These will appear yellowish brown in color, with red cells embedded in the cast. Now, don't get this confused with red blood cells. This is not the same thing as hematuria. Red blood cells in the urine can indicate pathology anywhere in the urinary tract. Red cell casts indicate pathology up in the kidney. White cell casts are seen in tubular interstitial disease, like acute interstitial nephritis, and also in acute pyelonephritis. And they can sometimes be seen in glomerular disorders, like proliferative glomerulonephritis. So anything where you have white cells and inflammation. But pyelonephritis is probably the most important one for you to know for step one. Now, I know these look very similar to red cell casts. They may not ask you to identify the cast based on the picture, but they might tell you something like microscopic examination of the patient's urine reveals the presence of white blood cell casts. Epithelial cell casts are seen in acute tubular necrosis because those necrotic epithelial cells get stuck in the cast. Epithelial cell casts will also turn up in acute interstitial nephritis and in certain types of glomerulonephritis. Granular casts are somewhat nonspecific, but they're most commonly associated with acute tubular necrosis. Granular casts occur when you have breakdown of cellular casts. So anything that causes red cell casts or white cell casts or epithelial cell casts could also cause a granular cast as that cellular debris is being broken down. So the debris embedded in the cast can be fine, like you see here, or it can be coarse, and the casts have a sort of dirty brown appearance, and they're sometimes called muddy brown casts. So when you see those muddy brown casts, think ATN. Fatty casts are hyaline casts that have fat globules embedded in them from epithelial cells that have degenerated. We typically see these in nephrotic syndrome. And if those lipid globules contain cholesterol, that may show up as a Maltese cross when you view it under polarized light. And then waxy casts represent the further degeneration of granular casts, and these are fairly nonspecific. They can be seen in a variety of kidney diseases, but they're associated with very low flow states, like end-stage renal disease. And that brings us to the end of session quiz. So pause the video, work through those questions, and then we'll go over the answers together. First question, what's the classic presentation of acute interstitial nephritis? Remember the mnemonic FEAR: fever, eosinophilia, azotemia, and rash. Next, what drugs are known to cause AIN? So we talked about NSAIDs, which is the main one, then several types of antibiotics, penicillins, cephalosporins, ciprofloxacin, rifampin, and sulfonamides, and then diuretics, PPIs, cimetidine, and allopurinol. And last question, what changes will be seen in a basic metabolic panel in a patient with renal failure? So the main changes to know about are elevated BUN and creatinine, potassium is often elevated, calcium may be low, and if there's metabolic acidosis, the bicarb may be low. That's it for now. I'll see you next time.